I would say that the biggest takeaway really should be is that these new agents, they are amazing. They're game changing, they're life changing, but they're not a big old band-aid that you slap on a diabetic.
Podcast RX.
Podcast RX.
Podcast RX. Podcast RX. Welcome to Podcast RX from Diamond Pharmacy, a show featuring the pharmacists and personnel behind the nation's largest correctional pharmacy provider. While we talk primarily about clinical and regulatory topics affecting the institutional healthcare clients we serve, we'll also occasionally get into the stories behind the people moving our company forward. This isn't just a pharmacy podcast, and you don't have to be a clinician or a pharmacist to enjoy it. On this episode, we welcome back Henry So, clinical pharmacist for Diamond's Optics team. As we recorded this, Henry was days away from giving an NCCHC conference presentation on evaluating high-cost therapies for type 2 diabetes patients. We discuss why he was inspired to develop a presentation around this topic, look at the use of different diabetic agents in special patient populations, and dive into his clinical rationale for helping providers choose between newer and often pricier agents and older, more established therapies. If you missed Henry's presentation at NCCHC, you can catch up with this podcast. All this and definitely more on Podcast RX. I'm Adam Campbell. All right, Henry So, welcome back to Podcast RX. Been a few months since we've gotten to talk. What's new in the optics realm and life in general?
Well, first of all, hi Adam. Thanks for having me back. Nothing really new these days. I'll be at NCCHC this upcoming first week of October in Las Vegas. So anyone that's going out there, just maybe we can meet up or catch a bite. But other than that, nothing's going on. What about you?
Oh, just living the dad life, you know. My hands are full. Working and dad life, that's pretty much it, but they're good things. But speaking of NCCHC, this episode actually is going to drop after you're out there, but either way, I wanted to have you on occasion of you going out to NCCHC, and you're going to give a presentation out there in Las Vegas about evaluating high-cost therapies for type 2 diabetes. And you know, you're going to talk about some things that are pretty evergreen. And I thought, well, what a great occasion to have you on and discuss this topic and further. So I guess I wanted to know, Henry, why did you decide to focus on this particular topic, high-cost diabetes medications, type 2 diabetes medications? And was this something you were working with through providers or in the optics department? Were you working through a lot of questions with them and you thought, hey, this is a great opportunity to develop a presentation? Or is this just an area of interest in your pharmacy practice? Which was it?
So the reason why I'm focusing on this, it definitely intertwines with the question that you asked. But we are fielding a lot more questions or requests for essentially high cost drugs, such as your Farxigas, Jardians, Ozempics, just to be more broad, like your GLP-1s and your SGLT2 inhibitors. Seems to be, from what I've noticed personally, and I think some of the other teammates we have, seems to be a decent split down the middle of providers just continuing medications from the community without too much consideration of why they're on these diabetes agents, versus the ones that are very well aware of the cost and the compelling reasons to use them outside of diabetes alone. And really, it's like, we didn't really discuss this with other providers, or there wasn't a lot of suggestion. It does come up in like a case by case basis because it is a very case by case driven problem where if you have these agents ordered and they do have these compelling reasons such as cardiovascular risk reduction, halting or slowing of progression of chronic kidney disease, weight loss, you got to find these things to be able to justify their usage. And one I slipped on, really important, has been heart failure. But it's really just in general, I just thought of this because I feel like our health partners, providers, whomever, they can really benefit from me discussing this either at NCCHC or if they saw saw me in the program and wasn't able to catch it, they can catch the podcast. But basically just giving them the ability to have better recognition for these agents. Not really like a specific recall or like being able to rattle off like, oh, Jardian's 10 milligrams, this, that, this, that. It's more of just like, yeah, like the recognition of the drug name and knowing like who to ask, whether it's the patient, a pharmacist for more data, or where to go to find out more to justify continuing forward with these medications versus not.
Yeah, and certainly you're doing a lot of that, I would assume, with the optics team.
Yeah, definitely. We have discussions about it almost every week, I feel like.
And of course, we've talked about some of the higher cost diabetes medications on this show. And Chris Bender and I, back several episodes ago, talked a lot about the GLP-1 agonists, particularly semaglutide. And yeah, the cost of these medications is quite astounding. And yeah, if you're looking to counsel providers into something that is more cost effective but still delivers the same amount of care, yeah, you have a lot of options there.
Yeah, definitely. I mean, cost is pretty much the name of the game. And, we do have agents like your tried and true metformin, or even some insulin therapies, albeit they have some safety issues. They're fairly comparable in terms of kind of pursuing the mindset of lowering A1C. But also, I mean, these agents the newer agents really are amazing. I mean, they've done so much for certain destitute patient populations, such as those with like heart failure and preserved ejection fraction.
In your presentation, you're looking at special populations among type 2 diabetic patients.
Yeah.
Can you talk a little bit more about that? What these populations are and how it relates to the strategy overall that you're putting forth in your presentation?
Yeah, well, the thing about diabetes, it's a very, very expansive disease state, which encompasses a lot of comorbidities, either those that predispose them to diabetes or diabetes itself, like basically conferring the risk of obtaining these comorbidities. So the different patient populations that I've basically boiled it down to, and obviously there's some guidance by the American Diabetes Association's guidelines. You have those with high ASCVD risk, so atherosclerotic cardiovascular disease. That can include your coronary heart disease patients, those who experience coronary death, something we definitely would like to avoid, your non-fatal heart attacks, your strokes, your hemorrhagic strokes. And we have our chronic kidney disease patients. And just to backtrack a little bit, I'm sorry. Diabetes in and of itself is a huge risk factor for cardiovascular disease. CKD, same thing, so on and so forth. Heart failure is the only one that kind of we're not truly understanding of or able to identify a clear link. But yeah, so like, for example, CKD, we have those where patients with their diabetes are progressing to the point where they lose kidney function and experience end-stage renal disease and have to undergo hemodialysis or peritoneal dialysis, both very, very uncomfortable, thrice or even 4 times weekly procedures. So then heart failure, I already mentioned. You have your heart failure patients. That's another one. Very fairly emerging in what we understand in terms of adding on some of these agents. I tacked in there hypoglycemia. And the reason why I did that is because hypoglycemia is becoming increasingly common, especially as we have aging populations that are utilizing insulins, even certain generations of sulfonylureas. And some of these agents are able to advertise the fact that they're able to have almost virtually no or very little hypoglycemic events. And obviously, consequences of hypoglycemia, whether it's fainting, passing out, subsequent things you can think of is like, you can fall, hit your head, break a hip, even blood sugars that are too low, you can end up in a coma, loss of consciousness, even death. And last patient population special is weight management. These two things kind of walk hand in hand in terms of diabetes and obesity or overweight status. So those are kind of the ones I just boiled it down to, and they kind of align with the newer agents that are indicated for these.
Now, when you're talking about these newer and more expensive agents, I believe that you go down through each of the populations you just talked about and kind of contrast the sort of established old school therapies versus the new ones. Can you tell me a little more about that?
Yeah. So basically for ACVD risk, I'll just start with that. So what we already understand about it is that there's a cluster of risk factors or cardiometabolic risk where it could be elevated cholesterol, really high LDL. Everyone knows the low density or LDL number that they're looking for. It needs to be below a certain amount. Um, there's blood pressure. There's genetics that have kind of come into play with our newer agents like alirocumab or the PCSK9 inhibitors, where if you have something like homozygous or heterozygous familial hypercholesterolemia, geez, mouthful, sorry, there's some people that are just genetically predisposed to having higher LDLs or lipids in their blood just because they're not able to process it. So just thinking about those things, and these clusters of risk factors, and I don't know if I mentioned, but things such as like smoking, physical inactivity, like sedentary lifestyles, and definitely unhealthy eating. Um, those are the kind of I wouldn't say that's a treatment, but those are kind of the risk factors you can think of, and you can modify those as appropriate. So high blood pressure, you lower it. If you smoke, use nicotine replacement therapies or different things like Wellbutrin or bupropion. Physical inactivity, go outside, do some exercise as long as your physician deems you able to do that. Unhealthy food, learn to build a plate. Um, Different things like that. And that's more of like the non-pharmacologic thing, aside from what I mentioned with smoking. But to pharmacologically treat these things, we have things like statins. Everyone knows their Crestors or rosuvastatin. You can use things like Zetia on top of that, especially if you can't get it down below a certain number like 70. We have antiplatelet therapies, usually reserved for those who've already had a cardiovascular event or some sort of just basically a cardiovascular event. Blood pressure agents, just reducing that. Your amlodipines, your ACE inhibitors, your ARBs. But yeah, those are kind of the older ones that if you want to be able to modify these risk factors for ASCVD, you use those. Then you have your CKDers, chronic kidney disease. I mean, these are those with declining renal function as evidenced by um, EGFRs that are trending down, increasing amounts of albumin in their urine. And they're pretty, CKD in and of itself is a really high risk factor for cardiovascular risk. So, these things are all kind of intertwined in like a very fine web um, of events and risks. And basically, our older agents, how we treat it, you can definitely use things like blood pressure, like antihypertensive agents. Your non-pregnant diabetics with hypertension, you can see things like ACE inhibitors or ARBs. Those have pretty strong recommendations. Um, Even like incorporating higher amounts of protein in their diet. Those are things that you can consider. Um, but yeah, basically also, I mean, you could consider certain things like a non-steroidal mineralocorticoid antagonist, like your spironolactones. But yeah, so that's kind of like where we are with like older school agents um, for CKD. Heart failure wise, I mean, it depends on two different things. If we're talking about older agents versus new, heart failure, I wouldn't really say it's older. It is, but it's more something I would define as established. Um, Heart failure patients, especially if they have left-sided heart failure or reduced ejection fraction, they'll use your standard agents for something called RAS inhibition, or basically something that's just suppressing something called the renin-angiotensin-aldosterone system, where that system is kind of amped up or ramped up in heart failure, where they're just kind of essentially just think of people in like a enhanced fight or flight state. Um, but yeah, you use things like lisinopril, your ACEs, your ARBs, losartan, newer agents like Entresto are coming out. You use beta blockers to control the heart rate because the heart is trying to compensate for a lot of different things because it's weaker. So it's, usually like above 80, 90, 100 beats per minute. So your beta blockers, your loop diuretics for symptomatic relief. And that's kind of like where we are with reduced ejection fraction. For preserved ejection fraction, we did not have many, we really had no agents for mortality benefits. So, kind of adding on a couple years back to someone's life, or just reducing the time to first death or cardiovascular event. We had a lot more on symptomatic relief as well as reduction of hospitalizations. But yeah, so that's kind of where we were if we had someone that had diabetes and heart failure. A lot of things that you could just combine, and things like your ACE inhibitors, they killed a bunch of different stones, birds with one stone. Um, reduces blood pressure, reduces chronic kidney disease progression, as well as having a role in heart failure. So if you had that trifecta or three different comorbidities at once, ACE inhibitors are great. Hypoglycemia, honestly, I wouldn't say there's like an older treatment for that. Really, it would be just kind of like assessing whether or not the insulin regimen, or let's say you have agents that, like certain sulfonylureas, that kind of collect or accumulate active metabolites in the setting of certain things like renal failure, especially our elderly patients who are having declining renal function. They might not be able to clear these drugs that are broken down into its active metabolites that continue to kind of like exert an effect. So discontinuing those, modifying those, using agents with lesser incidence of hypoglycemia, that would be kind of like the old school way, even though it still happens today. Weight management, this one's easy. I mean, you have certain agents pharmacologically, like topiramate, or certain stimulant-based agents that you can use. I feel like most people shy away from that. Really, the tried and true is just modifying your diet, exercising like 150 minutes per week, spread out over like 5 days. Um, just not leading a sedentary lifestyle. So things like that. Just that would be like kind of the old school way to put it. But just to make one mention that I guess a lot of people do know or don't know, I'm not sure. But a lot of our older diabetic agents, I mean, they do have weight loss. For example, metformin is associated with some weight loss, 2 to 3 kilos. As amylin mimetics, 1 to 2 kilos, things like that. So yeah, I mean, you could utilize those if you could transition to those, especially if you had a diabetic struggling with their weight and unable to modify their diet or increase exercise.
Now, of course, the purpose of your presentation and why you're bringing this to light isn't necessarily to bag on all the new agents that are out there. You're just trying to illustrate that there's still a lot of effectiveness to be had, even if it's not something like that's all wrapped in one package per se. What I wanted to ask too, Henry, what is the research that you've looked at say about the contrasting the established traditional therapies versus these newer agents?
Hmm, that's interesting. I mean, these agents in and of itself, some do have established cardiovascular risk reduction. Um, I mean, for example, or in terms of cardiovascular risk, they have pretty decent outcomes with metformin, but definitely you have to hit a certain threshold of a higher dose to be able to attain those risk factor reductions. Um, but yeah, when you compare and contrast, I don't. That's the thing. The best way to put it is that some of these studies that are being put out, they're only, the way that we're comparing and contrasting it is when we do something called a placebo-controlled trial, where if your intervention or the drug that you're using is, let's say, Jardiance, your placebo control, I mean, everyone knows like standard placebo is like a sugar pill, taking nothing. Um, But in terms of ethics and real world applicability, it's not like these patients that are in the placebo group are not taking anything at all. They're actually on established background therapies, such as your insulins or your metformins or your amylin mimetics. They are on those. So I guess every trial that is a placebo control, when they study it, they are able to observe quote unquote additional outcomes or additional benefit or risk reduction when you add on an agent like an SGLT2 or a GLP-1 on top of established background therapies for diabetes. So when you compare them, yeah, I mean, you can't knock them. They're great agents. They're being added on to already established and fairly stabilized patients. So they're definitely doing something more or giving someone an edge that is more than what they're already obtaining. And these patients are already optimally managed. So that's the best way I can put it in terms of not knocking on them and also praising them in that way.
Something that you talked about in our lead up to this before we turned the recording on was A1C management. And can you speak more to the importance of that, Henry?
Yeah, I mean, the importance of A1C management. I mean, the ADA and AACE, who is kind of just a bunch of endocrinologists that came together and made a recommendation. Yeah, it's important enough to take it to make a goal out of it as less than 7% or less than 6.5% in those that you're treating with diabetes. So it's pretty important from that perspective. Hemoglobin A1C essentially represents your average fasting blood glucose over the span of 90 days. For those that aren't controlled, you want to do it fairly often, but the most you can monitor it if they're continuously uncontrolled is every 3 months out of the year. Those that are controlled, maybe biannually. But A1C is the higher it is, the more predictive it is of poor macrovascular and microvascular outcomes. So things like heart attack, stroke, CKD, in your macro sense. Your micro sense is your diabetic retinopathies or your eye problems or neuropathies. So your nerve pain experience. So yeah, A1C is very important. It's been long established that more aggressive or lower A1Cs are associated with better outcomes. And just one little thing to add too, it's the reason why we can possibly see emerging use of newer agents, especially in relationship with hemoglobin A1C, is that you can have goals of less than 7%, but you can also have patients that have less stringent goals, maybe 7.1, 7.2, or something like that, because the older you are, or the more prone you are to blood sugar issues or other comorbidities or things such as, let's say, orthostatic hypotension or POTS or brittle bones, where a fall would devastate you in terms of a hip break. Those poor outcomes in terms of lower A1C goals may outweigh the benefit that you'd see from those lower A1C goals. That's why it's important.
Let's go back to the agents themselves and your everyday work as a pharmacist, as a consultant for this. What are the steps, Henry, that you take when you're helping providers determine the rationale for, if they have concerns over the higher cost diabetes medications and they're interested in maximizing the traditional established therapies? What steps are you taking to help them determine which is the best road to take?
Say it all the time. History, history, history. Take a history. Know what they've been doing. Know what they've been taking. Know what they've failed. Know what they cannot tolerate. You'll find that in the history. For example, you have people that have they're using a GLP-1 agonist, and they were right at the cusp of control, and they were at control, but they kept falling because they had like low blood sugar events relative to insulin. So yeah, I would say history is really important. And other than that, I mean, yeah, really history kind of encompasses everything. And what you presently see as well. So history as in what I just stated, their past medical history, like looking for something like a heart failure diagnosis, and what they're currently presenting with in terms of objective lab factors or other objective findings, such as poor renal function, um, high lipid values, things like that. So that's kind of how I approach it from the first encounter, just asking additional questions about their history.
I wanted to ask you a bit of a pharmacy nerd question, if you will. This is a question I would. This is definitely something I would pose to your colleague Chris Bender when we're talking. If you're looking at these therapies, which of the newer therapies really do you find the most interesting? Um, which which really stands out to you when you're looking through everything?
That's a good question.
What's your favorite? You know.
See, that's a little too nerdy for me because I don't have a favorite drug.
Yeah.
um, no,
And
I
that's too simplistic. That's why, hence why I regret,
no,
tried to
I
hold off saying it as long as I could.
you know what? You know what? I do have a favorite one. I'm wrong. I'll take that back.
Okay. All right.
Um, when I when I was in school, we were learning at the time that we had a heart failure presentation, and maybe like I think it was like a 5 hour total lecture or even 6 hour total lecture where I think like 4 hours of it was heart failure with reduced ejection fraction because there are a lot of agents that help with both symptoms and mortality. Whereas when we got to the last couple hours, it was just heart failure with preserved ejection fraction. And I remember our professor for heart failure was like, yeah, I mean, really not much to say. Manage your blood pressure, manage your symptoms. Spironolactone has a role, this and that. But really, we don't have anything that like reduces the amount of death or how often it occurs or how quickly it occurs. She even described it as when you at a certain point when you're told you have heart failure with preserved ejection fraction, it's almost like a death sentence. um, the prognosis was not good. But I would say, just to link it, I mean, Jardiance, when they came out with Emperor Preserved, that was very exciting. A lot of us were kind of fanboying over it, where, hey, like this is the first time ever where we have something that is actually showing mortality benefit for those with preserved ejection fraction or those with like a more muscular heart per se.
On the flip side of that, what would you say is the most underrated of the established or traditional diabetic agents?
Underrated, huh? Yeah, I would say, hey, there's nothing quite like metformin. I know that we see it all the time, but there's a reason why we see it all the time. It does have cardiovascular benefit. It obviously it reduces your A1C. You can lose a modest amount of weight with it. It is fairly safe in terms of hypoglycemic events. There's virtually none. And really, the only slight against it is its black box warning for like lactic acidosis and the conditions that are associated with the risk for it, as well as the fact that once you hit a certain EGFR or less than a certain amount of renal function, you cannot use it at all. But yeah, metformin, I would say, is really underrated. Definitely a favorite, and it's very, very, very inexpensive.
Let's go back to your presentation that you're going to be giving. Given that you're going to present this topic to correctional healthcare providers, the absolute bread and butter of who we work with here at Diamond, what for you would be the most important takeaway from this presentation? And say you're not giving a presentation, say you're just having a conversation about newer, more expensive diabetic agents versus older, more less expensive, more established ones. What's your takeaway? What's the main thing you really want to convey to providers when you're talking about this topic?
Um, Good question. I I would say that the biggest takeaway really should be is that these new agents, they are amazing. They're game changing, they're life changing, but they're not a big old band-aid that you slap on a diabetic, and regardless of other values such as the cluster of metabolic risk factors that I mentioned, like your lipids, your blood pressure, your hip to waist ratio, you can't just slap these agents on and be like done. they're covered. So I would say that's the biggest thing. And that kind of comes to light with some of these studies, Empareg being one of them, where in terms of traditionally managing diabetics, you have patients that are, at least when they're enrolled in these studies, most of the time they already have fairly well-controlled A1Cs. They're already on traditional background agents for diabetes. And we're seeing these being added on so that we can see additional benefit. But studies like Empareg and a couple others that you take a look at, they do subgroup analyses where they look at specifically those with an A1C of greater than or equal to 8.5% or less than 8.5%. And what you find in those is that when you slap on an SGLT2 inhibitor or your GLP-1, we have this thing called hazard ratios where, they range from 0 to 1 or a bit like 1.1, 1.2, 1.3. If you have these margins called hazard ratios or ranges that crosses 1, it means that you just really have no difference in the actual agent. Interestingly enough, these studies, like when you have these subgroup analyses available, you see those with fairly well-controlled A1Cs, see the primary outcome or the main benefit that is being communicated from the study, whereas those with uncontrolled A1C within those studies, they actually see no difference in benefit when you tack on these agents. So that just kind of, to tie that in, don't discount your older traditional agents and don't discount non-pharmacologic measures, because anything that can lower A1C in a safe way, as well as being mindful of hypoglycemic events, if you can optimally manage patients with those first, and you're still continuing to see poor outcomes, then maybe that's the idea in terms of when you should consider these newer agents, because they were added on in terms of those that were optimally managed for diabetes in the first place.
Well, that makes a lot of sense, Henry. And I do hope that you'll get to speak on this with a lot of correctional health people in the audience here in Vegas here in a few days. Want to wish you a safe trip out there and break a leg with your presentation. And I want to thank you again for being on PodcastRx.
Thanks, Adam. I really appreciate your time, and hopefully I'm on again. I know I'm not on as often as your favorite Chris, so really looking forward to those invites.
Yeah, no, of course. There will be more forthcoming, I can assure you. All right, Henry. Thanks so much. Talk to you soon.
Have a good one. Bye.
PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein. But we do hope you enjoyed them.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Keep up with our show on all the major podcast platforms, including Apple Podcasts and Spotify. New episodes usually drop the first full week of each month. Where possible, please rate and review the show to help us reach more listeners. If you have any questions or feedback for PodcastRx, we'd love to hear it. Shoot us an email at podcastrx@diamondpharmacy.com. We thank you again for listening.